Welcome everyone. We will get started. Um, we are excited to have Kirk talk today about the toxicology. Um, these webinars are brought to you guys by the Northeast South Dakota Area Health Education Center, as well as the South Dakota EMS Association District 4. Without any further ado, I will hand it over to Kirk.
Awesome. Well, thanks so much for having me. This is my first time hearing of AHEC or doing any talks, so this is exciting. Anytime I can talk to fellow EMS providers or students is always exciting for me. A little background about me. I spent 9 years active duty Navy right out of high school. Then I got out and then I spent 27 years doing fire EMS. I'm still doing the EMS, but I'm retired from fire, hence the beard. Waited for 36 years to get this thing. But I am still doing some EMS. And then my primary job right now is I'm a certified specialist in poison information, which is at CSPI. It's a national certification supposedly qualify me to talk about toxicology. And I've been at the Minnesota Poison Control System, which also serves the Sanford, South Dakota as the Sanford Poison Center for 25 years now. So I'll be retiring in about 3 years down to my farm in Kansas with my donkeys and my chickens. But until then, I'm still excited to talk with my fellow EMSers about toxicology. Really passionate about this. And a lot of the reason behind that is because I did EMS for 2 years before I got on the poison side of things. And I remember responding in my first year, in my first fire department, as BLS. And we got a call for a 4-year-old who drank bleach. And we're all like, oh my gosh, bleach kills kids. Bleach is bad, blah, blah, blah. And of course, we get on the rig. I always sat in the back for the 27 years that I was in the fire service. Kind of the knuckle dragger guy. Never wanted to be an officer. But so we're sitting there going, oh my gosh, how bad is this? I don't know. I hope the kid's still gonna make it, We get there, jump off the truck, smiles on her faces, BSI scene safe, kids screaming, so he's got a good airway kind of thing. And still, put on the smiling professional face, but still really worried inside. All of us were. I had no idea that at that time I could call the poison center and say, hey, we're responding to a 4-year-old child who drank bleach. What do I do? Is he going to die? And so that is available to everybody here in every state, actually. But since we are your poison center service provider, you'd be calling us. And so we welcome the calls to us. And we really want to hear from you guys out in the field because we get our best histories from you all. So that kid, actually, that bleach is only between 4 to 9% sodium hypochlorite. That amount of sodium hypochlorite is not enough to cause anything in a young child, except for vomiting on who's ever in front of them, and that's it. The strength of the poison center is that 92% of the time you call us, we can safely keep you at home. And not very many people die of toxic exposures, of overdoses, and that sort of thing. So that's kind of my passion about all this kind of stuff. I've also served as a death scene investigator for the Hennepin Medical Examiner's Office for 2.5 years, as EMS training officer for Lexington Fire, and then I've also been a expert witness for the Hennepin Prosecutor's Office under a different regime. So with that, we'll continue on here. Maybe. There we go. All right. So just a little fun. Summer is coming. So World UFO Day is July 2nd. So make sure you wear your tinfoil hat so that you'll get taken and get probed. So, all right. So here's kind of the impetus behind why I'm excited to talk to everybody in EMS is because we fear things we don't understand. Speaking personally about the training I got as an EMT in toxicology, it was make them puke, then give activated charcoal, and then get them to the hospital quick because they're all going to have bad outcomes. So my whole purpose today is to go ahead and let you know there's a resource to take the fear out of toxicology and let us be the experts. I jokingly say that, I only know how to do 2 things. I know how to breathe so they can stay alive, and I know toxicology better than 96% or 95% of ER physicians, because ER physicians have identified toxicology as the discipline of medicine they feel least up to date on. And so it's really easy when I can concentrate on one thing. So that's why we're there. So just a little about the poison centers. There are 55 poison centers in the United States that are accredited by America's Poison Centers. And that's kind of our medical direction. They're the ones that accredit us every 7 years as a poison center. In 2004, the Institute of Medicine identified regional poison centers as being the strength of as far as structurally, because we understand and have relationships with the hospitals that are within our state, our region. Oh, I think somebody's not on mute. Thank you. We understand in our region what our hospital's capabilities are. So for example, I recently had a case where there was a pediatric. Now, understandably, EMS defines pediatrics differently than hospital systems do. The hospital systems define pediatrics as anybody less than 18. And they lean pretty hard on that. So we had a like 16-year-old female who overdosed on aspirin. We already knew that she's probably going to require hemodialysis. We have 3 pediatric hospitals in the Twin Cities area, Minneapolis, St. Paul, which is where the poison center is out of. And we got a call. And we said, you know what? Sorry, I keep getting these stupid hospital pop-ups. All right. So we got a call. I understood that she's probably going to need hemodialysis. And we know at the poison center that out of the 3 pediatric hospitals in Minneapolis, St. Paul, only 1 can do hemodialysis. The other 2 can only do CRRT, which is not appropriate for aspirin toxicity. So we referred the consulting EMS to go to the hospital that could do hemodialysis. They didn't make it there. They brought them to another pediatric hospital, and they called us and we said they need dialysis, and they said we know, but we can't do hemodialysis. And so they said, why did you send them here? I said I didn't. We recommended the key words, that they go to Masonic, where they can actually do hemodialysis for pediatric patients. So that's the power the poison center can bring. So unfortunately, it didn't work out in that case. The patient did get dialyzed, survived, did fine, kind of thing. But when we were aware of the patient and gave a heads up to the pediatric hospital that could do hemodialysis. So that's why regional poison centers are really important. The other part of that is we understand the plants and the animals, the flora and the fauna, in scientific terms, of what's in our area. So I say, unfortunately, we don't have very many venomous snakes in Minnesota. Just in the southeast corner, we have timber rattlers. But I know in South Dakota, in at least almost 2/3 of your state now, because their area, their demographic, or their geographic distribution of prairie rattlers, the Viridis, is in about 2/3 of your state now, and you guys do get envenomations. And I specialize in bite stings and envenomations that have been published on the prairie rattlers. So that's why we like regional poison centers. The staffing at our poison center, out of the 55 poison centers, only 3 staff primarily with pharmacists. And you guys are lucky enough to have a poison center that represents you that has all pharmacists except for me. Why is that important? Most of the poison centers actually have RNs, or nurses, and obviously being a nurse, I have a little bit of bias towards that. But part of the reason I got to the poison center is because I was unhappy with the pharmacological training I was receiving as a nurse. And so I'm just a 2-year community college nurse. So we didn't, but we got the same, academically, the same curriculum that the 4-year nurses get at like the U and such. But so that's why I went to the poison center. But so here's another thing that you can use the poison center for, either in your personal or professional lives, is if you respond to a patient who's, in heart failure, they're on digoxin, maybe they're on flecainide, and they're on a beta blocker like metoprolol and diltiazem and that kind of stuff, and they double up, or maybe they have a little dementia and took 3 days worth of their meds. Guess what? We understand the pathophysiology, we understand the half-lives, and all the pharmacokinetics of all that, and we can go ahead and reliably tell you if somebody got a double dose, what the implications are. So some of the other poison centers that staff with RNs can't do that without having to consult their medical directors that are on call. We are not under that kind of veil, so we can go ahead and discuss that right off the bat, because we have pharmacists that staff the poison center. So that's the advantage that we have here in North Dakota, South Dakota, and Minnesota. So we're pretty happy about that. So we are open 24/7, 365. We are HIPAA compliant. So if you call us, you're not violating HIPAA. As a matter of fact, if you call us, once we get the case, we follow until the toxicological end, and usually that's the medical clearance of the patient. So we follow them through their whole clinical course. And so we know what happens to them. If you consult us about a patient, and a lot of times I know on my EMS side of things, we always don't hear how our patients did. But if you contact us initially about the patient. We can go ahead and you call us back later for maybe training or to see what their outcome was. We can go ahead and give you that information since you're part of the team now and that it is not violating HIPAA. Our poison center is located in Hennepin County Medical Center. I guess it's now called Hennepin Healthcare, but the old HCMC. We're one of 2 level 1 trauma centers in Minneapolis. And we've been out of there for 52 years now. That's how long we've been around. We are not technically part of Hennepin Healthcare. We are a not-for-profit. We rent the space from Hennepin Healthcare, but we do consult on patients that are in our hospital in person. I go upstairs with the Tox fellows and basically their first year teach them how to manage overdoses. And by the second year, because they're already board certified ER docs getting their Tox board. By the second year, they're already basically telling me what's going on because they're way smarter than me. So we're located in a very large hospital, which is advantageous because we actually get to see people that are poisoned. And it doesn't cost anything as far as to the user. So your state does contract and does pay some money for us to do the phone service aspect of this. But for you as the user, you won't be asked for any funds. So here's some basic statistics that I aggregated. I was just actually in Elkton last week speaking at an EMT refresher course. So I aggregated these. So in 2023, we took a total of 6,827 calls for South Dakota. Now, if you mirror that against Minnesota, we took 53,000 calls last year. So obviously we have a larger population. But we took 6,800 plus calls for the state of South Dakota. Of those, 156 were from EMS. My whole goal is to get EMS to call more. And hopefully after this presentation, you'll feel more comfortable and realize the benefits of calling the Poison Center. 43% of those callers were healthcare providers. So here's the deal, almost half. If you bring in somebody with a poison exposure, whether it's chemical, biological, whether it's an overdose, something like that, some over-the-counter medication, about half the doctors are going in the back room and calling us. And here's the power of the Poison Center is, if you call us first, we can get that history. And that history is super important. And I know a lot of times for you that are in BLS, kind of got into it thinking you're going to pound on chests and save a lot of lives. And, I've saved a few lives in my time in the 29 years that I've been doing EMS. And it's really exciting. But by and large, most of it is going to, falls and just kind of your nickel and dime stuff that are still important for us to go to. But the biggest thing that we have to do is get good histories. And a lot of us don't like to do histories, right? I was the weird guy in my department that said, I'll do the report afterwards and wrote pages and pages because if you didn't document it, it didn't happen. That must have been the nurse in me. And I'm kind of a ODD. So OCD, I'm sorry. So there again, most of the healthcare providers are going to go ahead and go in the back room and call us about half of the time, just under half the time. 36% of those patients were kids under the age of 6. You talk about somebody or a group of people that if you have a bad day with them from your EMS standpoint, that you're going to remember it and maybe get some trauma from it, potentially PTSD, it's going to be kids being harmed. So that's a majority of our people that we take as far as pediatric patients go that are under the age of 6. So that's kind of the demographics of who we serve. So this might be common sense, but the route of exposure that's most common is obviously ingestion. So primarily when you go on a call, most of the time it's going to be ingestion, way over 75% of the time. So this is a slide. It's a little bit busy, but basically these were deaths that were reported to the Minnesota Poison Control System. So these are Minnesota deaths. I don't have access to the South Dakota deaths, but these are the Minnesota deaths. Remember, we took 53,000+ calls. And these were deaths in 2022 that were reported to us, we consulted on. And these were deaths that only had one agent that they overdosed on. So you can see here that acetaminophen killed 11 people in 2022 as the only thing that was ingested in Minnesota. And that's because of end-stage liver damage from leaving the acetaminophen in there too long untreated. The second one, no surprise to anybody, opioids, whether that's fentanyl, heroin, butyfentanyl, OxyContin, whatever, all comers as far as opioids go. Number 3 is bupropion, otherwise known as Wellbutrin. Wellbutrin, we had 6 deaths. Wellbutrin is a very nasty drug and overdose And as you guys, being pre-hospital and EMS entities, know, a lot of people are on it. Here's the deal. It's called a phenethylamine. That is the chemical class that it's in. And that translates to being a hallucinogenic amphetamine, which actually is technically a bath salt by street terms. So Wellbutrin or bupropion is a bath salt. It's a hallucinogenic amphetamine. So why in God's name do they use it? Because it's effective for people that have major to moderate depression and some other things. And here's kind of a quick reason why is basically if you have depression and they prescribe you Prozac, Zoloft, Paxil, Lexapro, Celexa, the typical things that are given, those are basically CNS depressants. They also come with a very high incidence of sexual dysfunction. And so basically, if you're already depressed and you're on something that's going to go ahead and impair your sexual function a high percentage of the time, you're probably going to get more depressed. Well, Wellbutrin or bupropion being a hallucinogenic amphetamine, you don't have that problem. There's very, very small incidence of sexual dysfunction. So that's one of the positives of why they go ahead and prescribe it so much. The problem is it's got what we call a very narrow therapeutic margin. So people are prescribed 600 milligrams a day sometimes, 300 in the morning, 300 at night, and 600 milligrams daily is the maximum therapeutic dose. There are some doctors that are prescribing 450 BID. They're outside of the FDA's recommended dosing, but they can do it, in an off-label or because of their experience. But anything in clinical trials, 1% of the people that took 600 milligrams a day had seizures. 1%. Doesn't sound like a lot, but for a medication that's so widely prescribed, this is why we see people that double dose on their bupropion sometimes have seizures. Now, they're usually short-lived and self-resolved. But just to let you know that if you go to an overdose of bupropion or Wellbutrin, I don't know what happened there, you're probably going to go ahead and have seizures with them. And it can also cause sodium channel blockade, which will result in basically getting widened QRS, and you can also get torsades. So pretty nasty. And you can see the rest here. All right, activated charcoal. Now we've gotten away from using syrup of ipecac now, which is what we used in my BLS role back in the day. And so back in 2002, December 2002 and January of 2003, the American Academy of Poison Centers, or the American Academy of Pediatricians and the American Association of Poison Control Centers both said that syrup of ipecac should no longer be used. Here's the reason why. There's never been a good prospective study to show that any method of decontamination, whether it's activated charcoal, whether it's pumping somebody's stomach, i.e. lavage, or going ahead and giving syrup of ipecac, ever improved a patient outcome. But in a small percentage of the time, it actually caused things like aspiration pneumonia in addition to their overdose. So that's why we got rid of syrup of ipecac. Now, we do use charcoal. I don't claim to be a doctor, but I'm just the nurse. But if I were an EMS medical medical director for a rural BLS ambulance, I would definitely recommend that they put activated charcoal on the rig. I would put the caveat to that it should not be used unless poison control says it is. So the general rules are, if it's potentially life-threatening, it's within an hour and they can drink it on their own, then we give it. Otherwise, we don't. There's a few exceptions to that. For example, if they've taken something that we know they're going to die from, they have the potential of they're already very symptomatic, then we might consider putting an NG tube down, giving it to them, which I understand is not a BLS treatment modality. But once they're intubated, we can put it down the tube at that point too. So we do recommend calling poison control before using activated charcoal. Generally, the dosage is 1 gram per kilogram for children. And then for adults, it's between 50 and 100 kilograms. So if they're heavier, we give them 100 grams. If they're lighter, we give them 50 grams if they're adults. Preferably without sorbitol, but we're not going to split hairs. But try and call poison control before using it, because you can do some harm with it, actually. All right. So here's a mnemonic, and some of you guys go, oh, no, not another one. Another one's like, I love mnemonics. So here's one that we use in toxicology. Now, obviously, you guys have your sample histories, right? Very well familiar with samples. That does okay. but we ask you weird questions in toxicology. And so this is a mnemonic to help you kind of remember, what to do in a tox emergency. So M is for what medication or material were they exposed to? A is for the amount and the formulation. We'll get more into that. T is for time of ingestion or last known well time, which is probably mostly what we're going to get. Treatments, either that have been done by you or treatments that we're going to recommend as poison control. Emesis, R is for the reason, intentional, unintentional, suicidal, that kind of stuff, having a bad day. And then S is for signs and symptoms that are happening, so you can describe them to us. And then based on their overdose, what we would expect from that overdose that we can tell you. So hopefully that's helpful to you. This is something that we use every day at the Poison Center as we're evaluating things. It just becomes second nature. So as far as the emesis goes, we want to know what color it is. We want to know if there's pill fragments in there, because here's the reason why. Intuitively, we think that, let's talk about the anatomy and physiology of our GI tract. Basically, you have one in, one out the other end, and then hopefully no breaks in between. And there's a couple of pouches here and there and that kind of thing. So basically, it's intuitive that if we have a stomach which is near the mouth and we have somebody's ingested a whole bunch of something bad and we vomit it up, we can get it back. They've actually done a study where they gave people 100 placebo tablets. They made them vomit immediately in the best clinical setting. The best return they ever got back was 40% or 40 pills out of the 100. Okay. So that means that if somebody vomits and you see a lot of pills, oh, they must have vomited them all out. No, that means there's still at least 60% in there and probably more like 70 some percent, because the average they got back was 33 pills out of 100 under ideal circumstances. So making them vomit is not a good idea because it's not going to get back a meaningful amount if they've intentionally overdosed. So if you see pill fragments, that means that they took a large overdose and they're serious. We'll get, the friend of the 15-year-old, my friend, she took 200 ibuprofen. It's like 200. How long did you sit there and eat those? And it's like, then EMS calls and they're like, yeah, we got this 15-year-old girl, so-and-so. She says she took 200 about 2 hours ago. Has she ever vomited? No. That seems pretty unusual. But if the EMS crew says, yeah, she vomited, we can see pill fragments. Yeah, she probably took 200. So, and then the amount and how many times I'm less concerned about. But the color and if there's pill frags are important. Here's the other one, time of ingestion or the formulation. This is where you guys shine, and this is where it's super important to call the Poison Center. Because if you call me up and you say, I have a 64-year-old male who's taken a large amount of his metoprolol. So metoprolol is a beta blocker. And I understand that some BLS may not know all their pharmacology or whatever, but this is something that reduces the squeeze of your heart and reduces the rate of your heart. So that basically they die of hypoperfusion. They get hypotensive and bradycardic. Those are your first kind of clues that they're going to have a problem. Now, going back to the scenario, 64-year-old, you call me, say a 64-year-old male's intentionally overdosed on his metoprolol. My next question is, which metoprolol is it? What do you mean? There's only one kind. What is it, tartrate or succinate? I don't know. What's it say in the bottle? If you're still on the scene, you can still see the bottle. Well, it says tart. Oh, okay, that's short for tartrate. Or it says suck, short for succinate. So, and the most common time that in polls and in studies that EMS has shown up is 1 hour after overdoses, by and large. It could be a lot earlier and that could be sooner than that. But by and large, most of the time is an hour that we see most. So you call me up and my next question is, you say, all right, it's metoprolol tartrate. All right, what's his heart rate and blood pressure? Well, his heart rate is 51 and his blood pressure is 81 over 43. Ooh, I said ooh because my sphincter just tightened, because that's going to be a bad day. And you say it's metoprolol tartrate and it's been 1 hour. Well, here's the reason. Metoprolol tartrate peaks in 1 to 2 hours. This is one of those where you could be unseen. If they are bradycardic and hypotensive, you better get to your ALS intercept, and that ALS intercept better get you to the hospital quick, and preferably to a large hospital. Understandably, they can do some minimal stabilization at a smaller critical care access hospital, but they're eventually going to have to be flown, if they survive long enough, to a larger hospital that can do much more advanced things like high dose insulin and those sorts of things. So Now, if you call me up and do the same scenario, 64-year-old male, ingested a bunch of his metoprolol, and you tell me it's succinate, and it's been an hour, and I say, how long ago was it? And you say an hour. Guess what? And I'll say, what's his heart rate? It's 91. What's his blood pressure? 135 over 92. Good. No problem. Just do the typical, get your history, that kind of stuff, get them en route to the hospital, whether it's you or ALS Intercept, or if you're ALS to the hospital, and then get him there, because he's not going to have significant problems until 6 to 12 hours later. And then that gives us time, if it's at a critical care access hospital, to be able to get him to a very large hospital, like a level 1 or level 2, where we can go ahead and do some more significant treatment modalities, because treatment's going to get very complicated in this patient. Carbon monoxide is a leading intentional poisoning killer in the United States. So we can see carbon monoxide even in the summer. We've actually done studies around boats that are idling during the summer and found that people that were normally known to be strong swimmers have drowned, because we've taken carbon monoxide measurements around the bottom of the boat while it's running, and carbon monoxide levels have been high, and they probably drowned from carbon monoxide poisoning. But the most common thing is obviously in the winter. We just got stuck with a spring snowstorms, because we get kind of lucky in Minnesota anyway from a snow perspective. But we see a lot of this. So anytime a flame is burning a carbon type of fuel, it will produce carbon monoxide. It's odorless, colorless, and tasteless, as we all know. So the M is for what the material is. The S is for signs and symptoms. The first signs and symptoms you'll see will be a headache, one that feels like your hat's on too tight. You'll also get nauseated, maybe vomit, and you'll also get tired. That's at about 100 parts per million. For those of you that have 4 gases that are attached to fire departments, if the ambient parts per million of carbon monoxide is 100 parts per million, people can go ahead and start having these symptoms. If the parts per million on your 4 gas are greater than 1,000 parts per million, then half the people that are there for more than 30 minutes are going to die. That's the LDLC 50, is 1,000 parts per million. And the treatment obviously is fresh air, which in 4 to 6 hours will completely remove all the carbon monoxide in your body in ambient air. If you put them on a non-rebreather via high flow oxygen via non-rebreather, it'll clear it out in about 30 to 90 minutes. So there again, no matter what level of EMS you are, oxygen is a medication we all have access to. Get them on it quick. And then give the poison center a call, because we have a large hyperbaric chamber, multi-chamber at Hennepin Healthcare. We're the only one in the region that has a multi-chamber, and we can start making arrangements to get them flown over to us if we deem necessary. So here's something else you might want to consider. So I can tell you that I have family members that live in northern Minnesota, and about 30 minutes from where they live, so about 2.5 hours from the city, is that straight up Highway 10. There's a little town called Perham, and actually Vergas is right next to them. And they, about a few years ago, well, in 2016, they had somebody, a mid-50s-year-old male, who was having a cardiac arrest. So the sheriffs got there first, because it's a rural environment. Sheriffs start working them, they start pumping on them. The volunteer BLS ambulance gets there, they start working on them, and they all start getting headaches, vomiting, and drowsy. Some started getting confused. Well, guess why? Because there was undeclared carbon monoxide in the house, which is why this gentleman who had pre-existing cardiac problems went down and had a cardiac arrest, because his carboxyhemoglobin is quite high, unbeknownst to the responders. 3 of those responders had to go ahead and be flown down to Hennepin Healthcare and put in the hyperbaric chamber. So what I've always advocated doing with the fire departments I've been involved with, and one of them does this, one doesn't, because I don't know, the chief and I don't get along, so he doesn't like me, so I guess that's why he doesn't do it. But and then in the Lexington fire, where I was the EMS training officer, they did this. But they get these kind of what we call disposable carbon monoxide detectors, and you strap them onto your first in medical bag. They're good for about 2 years. They're under $200, and I would encourage everybody to have one of these on their first in medical bag, because of the carbon monoxide, because it's odorless, colorless, and tasteless. If you don't have access to that and you're on a fire department, whenever I was the officer on my duty crew, or on my crew, when the officer was gone for that day or on vacation, I'd clip my 4 gas onto my lapel of my jacket, my bunker jacket, and just leave that on the whole time so that I could know if there's any carbon monoxide being emitted in the environments that I was in. So just a little tip, if you got a couple extra $100 to buy something, this is a good investment. So I don't know if any of you are grandparents out there, but you guys are the most dangerous people to have around your grandchildren. So I don't have grandkids yet. I'm old enough. I've got a 34-year-old, a 27-year-old, a 23-year-old, and a 20-year-old, but none have produced yet, which is fine by me. But my brother, who's 2 years my junior, he's already got 7 grandkids. He's the most dangerous person to have around. And most of the reason for that is they forget that how curious young kids are, and they get into their pill minders. And maybe that could be a 260 milligram diltiazem. That pill could kill a 2-year-old because it's a calcium channel blocker. So just remind, especially now with Easter coming, grandparents are going to come. They want to see the little ones. They're going to come with their pill minders. Just remind them to keep them alpine out of sight, or preferably down low and locked up somewhere. In the purse is not good enough unless the purse locks. This is the most common thing we're talking about nowadays. As you'll find out, the Poison Center isn't just about poisonous things. These water beads are actually non-toxic. And so what happens though is when you put them in water, they expand, right? Some expand to about 1.5 times their size. Some don't expand at all. And some expand to up to 10 times the size that they originally were, like the Orbeez and things like that. Here's the problem when you swallow that, when a little kid swallows them. Their airways and their GI tracts are little tiny. I mean, they're very, very small diameters, right? And as they travel through your GI tract, it picks up the mucus that lines our GI tract, and that is water, and that expands them to the point where they can go ahead and expand large enough in their small intestine to cause a bowel blockage. And that's really the concern with these. So obviously a bowel blockage is not going to happen immediately, but we do encourage parents to watch their kids to make sure they're not getting constipated. And if within the first 24 hours they have any nausea, vomiting, anything like that, we send them in to go ahead and get imaged to see if there is a potential bowel blockage. But these things in and of themselves are not toxic, but they have the potential to cause that. And the reason for that we get dumped off for this is because it really doesn't fit into a certain category. So basically, I speak at trauma conferences, and a lot of times poisoning isn't trauma, but they don't know where to put it. So we're kind of the stepchildren of a lot of different disciplines. But as a result, we get to hear about things like rabies, which is more of a disease pathology. We're the experts in rabies and things like this. So if you don't know where else to call about something, you're probably going to get routed to the Poison Center, or we know at least have heard about it, and we can direct you to the proper authority to discuss things. Here's another one, magnets. So the magnets in the colorful cube down below here actually are being sold up until about a month and a half ago by Target, Amazon, and Walmart. Well, these are very powerful magnets. And what happens is when you swallow them, or the water balloon, the disposable water, not disposable, the reusable water balloons that are held shut, like in the top picture, those are held shut by magnets. When you throw them, of course, they fall out and then kids eat them. Here's the problem. If you swallowed one magnet, it's not a big deal. The magnets themselves, there again, are not toxic. None of the metals in there are a problem. There's no lead in them, so not a big deal. They should pass through uneventfully. The problem is that you ingest more than one and they're in different parts of your small intestine. If it's going through adjacent loops of it, they are so powerful that they will attach to each other through adjacent loops of small intestine. And if they do that, if they're adhered for more than a few seconds at a time, it will cause ischemic bowel. So we had a case here in Minnesota in 2019 where a 3-year-old girl died mysteriously. She was otherwise healthy, no mechanism. So they autopsied her, as you would imagine, and they found 13 magnets in her gut that were adhered to each other in different parts of her bowel. And she died of ischemic bowel and sepsis. So there again, not much we can do other than recognize this and then get them somewhere where they can get x-rayed in a relatively short amount of time. So we can either say, oh, they're not there, or there's only one, or, oh, they're in different places, they're not stuck together yet. And then we can make recommendations to the respective pediatric gastroenterologists as far as how to treat this. Multivitamins in kids, even adult ones. So they're in gummy form. I know I take B12 in gummy form because I'm on metformin. So if you have metformin, you get B12 deficiency, which my students astutely told me, my pharmacy students. And so I started taking B12. They taste pretty good. But as far as any multivitamin goes, if kids are left alone long enough, they can go ahead and just munch down a whole bunch of them. Here's the deal. The only thing we're worried about in any multivitamin, whether it's adult or children's, chewable, non-chewable, gummies, whatever, is the iron content. If there's iron in them, you need to call us. We need to know weight, potentially what the child weighs. We need to know how many milligrams of iron. And in a pediatric formulation, they can't have more by federal law than 18 milligrams of iron per gummy. And so try and figure out how many there are per gummy, and we can do a calculation. And if they're over 35 milligrams per kilogram, we're going to send them in for serum iron levels. If they're under that, we know through studies that it's not going to cause any toxicity. And it would take dozens in a normal weighted 3 to 4-year-old to do that. So it's worth your time to give us a call to prevent a needless emergency room visit. And as far as that goes. So we don't care about anything else in a multivitamin except the iron. All right. Yay. So here's something else that has what we call a narrow therapeutic margin, windshield washer fluid. How many colors does this come in? Well, I know of orange, red, purple, green, and of course the blue. But it's got a child-proof cap on it. Guess what? They don't make child-proof caps. The way that the Consumer Product Safety Commission makes caps child-resistant is they line up 100 Billies and Susies. They give them the type of cap in the whatever container they want. And if less than 19 of them can open it within 10 minutes, they bless it as child resistant. So that means that any cap that's considered to be what you call child proof or child resistant, the more correct term, that for that particular cap, that up to 19 kids out of 100 could have gotten into it within 10 minutes. So just leaving you with that. So windshield washer fluid looks like juice, right? Right now, with the weather the way the weather's been lately, we've had to use a lot of this. People throw it in their bottles, sometimes in Gatorade bottles to dump on their windshield as they're at stoplights, and it's in cars. One sip of this in an adult or a child left untreated can cause blindness, either permanent or temporary, and can cause potentially systemic acidosis and kidney problems. This is one of these things where it's got a narrow therapeutic margin and it doesn't take much to be a problem. And here's the problem. You only have one healthcare facility in your entire state that can get methanol levels, and that's Avera McKinnon in Sioux Falls. So this makes it very difficult to manage from a medical perspective and when to treat. So this is one you should always definitely call the Poison Center on, because we do have protocols without being able to get methanol levels on how to manage the patient potentially. So this is one of those oh crap ones. So more common things we see every day. Aspirin, we abbreviate it as ASA because it's acetylsalicylic acid. It's actually an acid. That's its chemical name. And if you take enough of it, you can get a systemic acidosis. And that's it's easily dialyzed. Not all medications can be dialyzed easily. Aspirin can be, and that is the definitive treatment. But first of all, before we do that, we can alkalize that and give them sodium bicarb to try and balance out. Kind of like in hazmat, you try and neutralize stuff. If they're acidic, we'll go ahead and give them some sodium bicarb. If that doesn't work, we'll dialyze them. Acetaminophen, as you see, the reason that it's the leading, at least killed more people in 2022 in Minnesota as a single ingestion was because it's so prevalent out there. We buy the big giant bottles of them from Costco that have like 1 million in there. And then, so it's just availability. We do have an antidote that if we get it in within 8 to 12 hours, it will cause no damage, as long as you don't have pre-existing liver damage. Our liver is pretty forgiving, thankfully. Spending 9 years as a drunken sailor, I probably wrecked 2/3 of mine, but you only need 1/3 of your liver to survive appropriately. So I'm lucky in that regard. But it's pretty forgiving, but there are points where if you take too much and don't get treatment, that it's a problem. So what do you look for? Whether it's a toxic overdose or subtoxic overdose, you can still get nausea and vomiting and abdominal pain, and you don't know whether it's toxic or not. We have to get levels, and we have to follow LFTs, liver function tests. So anybody can have GI effects even from taking 5 or from 500 of them. Ibuprofen. Oh, that I didn't correct the slide. Liver toxicity should be where GI effects is, and GI effects should be where ibuprofen is. Sorry, I missed that, and I thought I corrected the slide. So it's GI effects for ibuprofen and liver toxicity for acetaminophen. Between you, me, and the wall, as a general rule, ibuprofen is very, very difficult to take enough of and to cause serious illness or death from. So most of a vast, vast, vast majority of everything you're going to go on ibuprofen wise, if that's the only ingestant, are not going to have significant outcomes by and large. That also runs for non-steroidal anti-inflammatories, NSAIDs that are over the counter, such as naproxen, so Aleve, 220 milligrams. Generally are well tolerated in overdose. They look pretty sick, but they generally don't do too bad. All right, so let's talk about drugs of abuse. So here's the first thing I want to teach you about drugs of abuse and managing them from an EMS perspective. Nothing is what it seems. Everything is just assume everything is counterfeit or adulterated with something else. So you can see here that the Xanax, the Xanibars, the 2 milligram divided dose Xanibars, you can see the real Xanax and you can see the counterfeit on here. I can tell you, I actually have a picture of a counterfeit one that looks almost identical. It's white. You can't tell the difference unless you see them side by side. We had it tested by the DEA, and they found in this one case that this girl who was addicted to benzos, Xanax, took a whole bunch, woke up dead next to her girlfriend the next morning. I was on the death scene because I was in my death scene role in that one, and asked her what she took. She said, well, she just took her normal Xanax. She's addicted to Xanax. And I said, did she take more than usual? She said, no. So we had them tested, and there was actually fentanyl inside the Xanax. So had they known that and used Narcan on her, she might have lived. Maybe not. It depends how much fentanyl was in there compared to the Xanax. But the bottom line is nothing is what it seems. People are pressing pills. It's not hard to do, and they're putting whatever they want in them. We've seen something called blues or M squared. So these are supposed to be 30 milligrams of oxycodone. They are blue. The most popular one has an M with a square around it on one side and a 30 on the other side. And they're pressing pills that have fentanyl, carfentanil, everything under the sun. Cocaine, meth has been found in there. So things aren't even in the same drug class within one pill. So nothing is what it seems. Treat the patient, not the poison. That's going to be my biggest thing to tell you is treat the patient, not the poison. All right. So lots of adulterated stuff out there. So here's some new stuff. Woohoo. So this is, I can't even pronounce this. Metronidazine. So it's sold as oxycodone or opioids. It's also sold as cocaine, and it is a synthetic opioid. So this is one that we can't even really find in the blood on anybody, because in order to find something in somebody's blood, when you run it on a machine, it has to have the exact same thing as a standard inside that machine. And this isn't even legal. It's not even known in a lot of different states or nations around the world. And so they're picking up on these sorts of what we call novel synthetic opioids and using them so we can't detect them in their bloodstream, so they can't be vigorously prosecuted from a law enforcement perspective. Maybe some of you heard of Narcan-resistant opioids. Part of my job is to go ahead and nip these rumors in the bud, all right? This is not true whatsoever. Not at all. None of the opioids are getting Narcan resistant, all right? What they do is they have things in there that are not opioids, like we just discussed in the Xanibars, that are actually maybe they're not opioids. All right. So you think you're taking fentanyl, you shoot up your fentanyl, but it's got something else in there like this tineptine. This is a very unique drug that is not FDA approved in the United States. It is a antidepressant that's much like tricyclic antidepressants, which are dangerous in overdose, but also hits some receptors that are used in opiate overdoses too, the mu receptors. It's a very unique medication. There again, it's hard to detect since it's not technically illegal. It's in a gray area. It's hard to go ahead and prosecute vigorously for it until they do make laws for it. And so this is why if you take a bunch of this, it may not respond to Narcan, but it may be advertised as fentanyl. There again, nothing is what it seems. So if in doubt, somebody's unresponsive, we all know that Narcan's not going to hurt anybody if you give it to them and they don't need it. And there's probably a few of you out there that say, well, what about the flash pulmonary edema? That's pretty much non-existent in the doses that we give in EMS, even larger doses. So you don't have to worry about flash pulmonary edema. And that's the least of the concerns if that actually does happen. So please use the Narcan, even if you don't suspect, even if they don't have the pinpoint pupils from it. Even if they've decreased breathing, just give it to them, because there may be some aspect of an opioid that's either adulterating what it is, or it's being adulterated with that. So be liberal with the Narcan. Here's the other one, xylazine. We're seeing more of this in the Midwest. So xylazine is not an opioid, though we're finding lots of xylazine in fentanyl right now. It lasts for up to 24 hours. It's called trank or trank dope on the streets, or zombie heroin, and it's not heroin at all. It can cause exactly the same things like decreased breathing, decreased CNS depression, those sorts of things. And what else it can cause is these peripheral necrotic lesions. Now, this is not infection from using too many dirty needles. This is actually a main mechanism of the drug that we don't understand. This has not been approved for human use. This is another veterinary drug that is being used in human drugs of abuse. And this is what can happen if you are a chronic user. Now, if you use it for a week and it's contaminated with xylazine, you're not going to get this necrosis on your arms or your legs. But if you're using it for months, that's a possibility too. So just another good reason to glove up, right? So here's your typical classic opiate overdose toxidrome. A toxidrome is a constellation of symptoms for a classification of medication. So they get pinpoint pupils, they get respiratory depression or arrest, and they get CNS depression, all right? One of the things I want to caution you about, and this may seem obvious to you, but I get it even from ER docs. They'll be like, well, he supposedly took fentanyl and he was unresponsive, so we gave him Narcan. Okay, what happened? Well, now he's in withdrawal. He's screaming, and you can hear him in the background going, "You mother effers, you get." Anybody who's seen anybody in opiate withdrawal knows that they have very nice mouths. Okay, they're not happy people. And if you're BLS and only have the 4 milligram intranasal, you don't have a choice. You may just induce withdrawal, but better than them dying. My experience is that they personally, generally, as a rule, if they're in opiate withdrawal, sound like they want to totally tear you apart. They call your mom every name in the book, and some things I've never heard. But they generally are not violent. They're just a lot of mouth diarrhea for the most part, verbal diarrhea, and they're just pretty pissed off. So, but getting back to the story, like the ER doc, it's like, well, so we gave them a bunch of Narcan, they woke up. Okay, well, what was their SpO2 and the respiratory rate before when they came in unresponsive? Well, they had a respiratory rate of about 10, and their SpO2 is 92% on room air. Why'd you give them Narcan? They're on the cusp of not breathing adequately at a respiratory rate of 10, but their SpO2 is fine. Why wake them up just because they're unresponsive and give them Narcan just to do that? If they're breathing adequately and they're not saying stuff about your mom, take that. All right. So look at your patient holistically. Treat your patient, not the poison necessarily. So when I was an expert witness for the Hennepin prosecutor's office a while back, the first case I got was a gentleman who was busted with just over 7 pounds of pure fentanyl. So, a super fat chihuahua, about that amount. They wanted me to go ahead. He wouldn't plea deal with the FBI. So that's why the FBI didn't take the case to prosecute him. They rolled it off to the county. And so they hired me to go ahead and try and convince a jury of his peers on how bad 7.44 pounds of pure fentanyl could be to a population. So what I did is I went ahead and I calculated how many milligrams of fentanyl 7.44 pounds was. It comes out to 3.374 million milligrams of fentanyl. Now, if you had a big surgery and you were going to know that you're going to have postoperative pain, standard of care is to give somebody 0.12 milligrams of fentanyl to help with their pain postoperatively. If you're doing procedural sedation, such as endoscopy, colonoscopy, or maybe wisdom tooth removal, they give you 0.3 milligrams, and that's the equivalent in this case for 7.44 pounds to be almost 11.3 million doses. And then the lethal dose for somebody who's opiate naive, who's not on opiates, which is most of us, is 2 milligrams, is widely accepted to be the lethal dose in an opiate naive person. That represents 7.44 pounds represents almost 1.4 million deaths. So, and the way I put it is that's the entire populations of Minneapolis and St. Paul in their entirety, plus a couple first ring suburbs, everybody dying. Well, needless to say, the gentleman took the plea deal at the prodding of his defense attorney because I guess I laid it out pretty simplistically. But that's how potent fentanyl can be. So another thing I want to go ahead and address too, since we're talking about fentanyl, some of you may have been mistakenly taught another urban myth that I'm out to bust is that if it gets on your skin, it's going to absorb and cause you not to go home. That's total BS, folks. I've actually held pure fentanyl. I've seen people do it. You have to respect it, but you have to understand the routes. It does not absorb appreciably through the skin. There are patches, but it takes 12 to 24 hours and they're specially designed for it to go. And guess what? When you peel that patch off after 24 hours, there's still about 40 to 60% of fentanyl in there. So what a lot of people do is they'll take the used fentanyl patches, they'll cut them into 4 strips and sell them on the street for 20 bucks a piece because there's still good fentanyl in there. So that now, if somebody blows it in your face, if you like lick your finger and put it in a pile of it and go, oh, it doesn't taste like fentanyl. Yes, those are all enough to cause you to need Narcan. But it just being there with a couple of particulates in the air or getting on your skin, just wash it off. Don't freak out. Okay. It's not that dangerous. So here's the Narcan that most of us can use in the BLS world is the 4 milligrams. Now this 4 milligrams is the equivalent to 2.1 milligrams IV. But still, that's a lot of Narcan to give somebody if they happen to be addicted to it. And in some cases, it's enough to induce withdrawal. There again, withdrawal is not life-threatening from opiates. They would rather die than go through it, but it's not life-threatening. But they're just going to be really pissed off at you. So be careful as far as giving this. Now, if you happen to be ALS, and just start them at your traditional 0.4 and work up there until their respiratory drive is adequate, even if they're not awake. And once they're breathing adequately is the key word, then that's all you need. Don't forget this though, especially in BLS, we can go ahead and put an advanced airway in them. So in this day and age, I think most of us in the BLS are using eye gels and then bagging them, kind of thing. So don't forget that. We don't need Narcan to save somebody. We can go ahead and bag them till the cows come home. And I don't know how many of you guys use the rescue pod and rescue pump. On the fire department I just retired from, we use them and they save a lot of lives. But you got to make sure if you're using the impedance device, the pod, you got to make sure that you get a total face seal with a mask, which is why I recommend using the heels of your hand. Because if there's any air that comes through that mask, it's going to go ahead and defeat the whole purpose of that entire system of the rescue pod and the rescue pump. If you don't know what I'm talking about, don't worry about it. If you do, make sure you get a good seal. All right. So here's how opiate receptors work in our body. All right. So I'm going to be the opiate receptor. I'm going to be standing in the central nervous system waiting for something to come by that's going to give me a hug and make me feel really good. All right. So my wife comes by. That's her. She's going to be heroin today. She walks by and I'm like, oh. And after almost 30 years of being together and 27 years of marriage, she still is kind of my heroine. I give her a hug and I feel, oh, feels pretty good. Right. Well, Nicole Kidman, who's way hotter than my wife, is going to go ahead and be Narcan in this case. And so when I'm hugging my wife and Nicole Kidman comes in, I'm going to look and, of course, ask permission. Hey, Nicole, can I give you a hug? Absolutely. And my wife's like, no, don't give her a hug. It's like, well, get divorced. It's like, oh, sorry. This is the only time I'll ever hug Nicole Kidman. So I'm going to let her go in the presence of Narcan and go give Narcan a hug. That's how it works. When they're both present, now, keep in mind the dosages may change a little bit for the Narcan depending on the specific opioid that you have. But eventually, if you give enough of the Narcan, it's going to bump off the opioid off the mu receptor, which is the receptor in the central nervous system responsible for the euphoric effects of the opioid. Hopefully that makes sense. So It's just simply what we call it at the receptor sites called the affinity, how much it wants to go ahead and hug that particular thing. So it would rather hug Nicole Kidman than my wife, or I would anyway. Remember, opiate withdrawal is generally not life-threatening. Now, withdrawal from benzodiazepines such as Valium, clonazepam, that can be life-threatening. Withdrawal from alcohol can be. Baclofen, a skeletal muscle relaxant, that can be a life-threatening withdrawal. But opioids generally are not. They just are not. It feels like they would rather die. They think they're going to die, but they're not. So just remember that. So opiate substitutes. Excuse me here a minute. Dry throat. All right. So you have opiate use disorder. You need to get your opiates at least twice a day, depending which opiate you're using, sometimes up to 4 times a day. You start feeling the gnawing in your stomach happen. And you start feeling it go and go, and you're like, oh, this doesn't feel good. Well, that's when you know you're getting dope sick. That's what they call it, the addicts, when they have opiate use disorder and they go into withdrawal. It's called being dope sick. They need to go get their medicine, which is opiates. So they go down next to my hospital, let's say on 8th in Chicago, where drug dealers hang out, and they go buy their opiates, and then they feel good again. The gnawing goes away. They're good for a couple more hours until it starts coming back, and they got to get it again. So let's say they go there for their second round for the day, and their drug dealer's not there. And there's another guy who uses it you recognize, and hey, Bill, where's our dealer, man? Man, the cops picked him out. All right, well, let's go to Fifth in Portland then and see if we can find somebody over there. I hear stuff isn't as good, but we got to get something so we don't get dope sick. Yeah, I agree. And he's not there. Now you're in oh crap mode, because now these people start panicking. That knot in their stomach gets harder. They start getting their hair standing up, piloerection. They can get diarrhea. They start feeling like absolute garbage, and they got to do something. Well, here's what they do. They'll take gabapentin, which is not scheduled. We don't. There's some potential that people might get addicted to it, but it's really, really a very forgiving medicine. Now, its FDA approved uses are for as an anti-seizure medication, and then for different types of peripheral nerve pain. Its off-label uses are for migraines, fibromyalgia, mental illness, chemical dependence, and it's pretty safe. We like it, and so it doesn't give a hug to that mu receptor in the central nervous system at all. But what it does do is they say it takes the edge off their withdrawal. And it might do that. And they can take large amounts of it, and it's not going to cause any serious problems in an overdose. So we actually like gabapentin for them to use. So that's one option, is they can take a bunch of gabapentin. And I've seen people, I just had a case where somebody took 20 grams, 20,000 milligrams of gabapentin, and were basically just a little bit tired and staggered a bit. So it's a very safe medication. The other one, kratom or kratom. This is one that's totally natural. Let's say that you want to get off of your opiate addiction or use less of it. This kratom is totally natural. It is a plant called Metrogina speciosa. Love the name of that. It sounds so mysterious. And it will go ahead and hug the mu receptor in the central nervous system. The problem with it is you can develop dependence from it, just like you can opioids, and you can get seizures from it in withdrawal. So this is well known. So now you're taking something that wasn't life-threatening withdrawal that you're trying to treat naturally, and now you're taking this instead of your opioids, and now you try and stop, and now you start seizing. This is the call we get all the time. 34-year-old patient comes in, he's in the ER, he's seizing, and they brought him in. Well, what's his history? Well, he used to take kratom to get off his opioids, but he decided that he was just going to stop doing that so he could get off everything, and he had a seizure. Nope. So this is why things that are natural aren't always safer or better. So this can be potentially dangerous too, even though it's all natural. Tramadol. Tramadol is not a true opiate. It does partially agonize the mu receptor so that you do get some pain relief from it, some euphoria, but it's a dirty drug. And in overdose, you can go ahead and have seizures from it. So tramadol, you can get respiratory depression or rest, just like the opiates that it's replacing, and you can also get seizures from it. You can also get serotonin syndrome from it too if you're on other serotonergic agents. So if you do have a seizure from tramadol, we give benzos, just like every seizure that's induced by medications, by and large, 99% of the times we give benzos. I realize that BLS can't do that, but for you ALS people out there, that's what they'll need. And at least now for BLS, you'll know what they need. You just can't give it. So if you intercept, let the medics know that. Here's the other one that's interesting. Loperamide, the anti-Hershey squirt medication, otherwise known as Imodium AD, is the branded one. Little tiny Tic Tacs, right? So if your wife is pissed at you for hugging Nicole Simpson or Nicole Kidman, and she makes you a meal that's been sitting out for a while and just reheats it, and you get sick from it and have to pop one of these bad boys so that you can get through a day without having to stop every 15 minutes at a gas station and use the facilities, that's what this will do. So here's the reason that they do this is because if you look at its chemical structure, it looks a lot like methadone on the one side. And it's called poor man's methadone. At one point in time, it was scheduled. It was a Schedule 5, so the lowest potential for addiction. But they descheduled it after 1980 because the manufacturers went before the FDA and said, hey, there have been no deaths from this. Can we deschedule it? I can tell you at the Dollar Tree, the $1.25 tree, I should say now, because it's not a dollar anymore. The $1.25 tree up the road, I asked him one day, I said, what's your number one seller? Because I'm in there a lot. And I know the owner by sight. He kind of knows me. I don't know what his name is. But just one day I was curious because they do have a generic, this brand here of the antidiarrheals there. And I said, hey, what's your number one selling product or what's one of your best sellers? He goes, you wouldn't believe it. I said, let me guess. I said, the antidiarrheal. He looked at me, he goes, well, how'd you know that? I said, because you got a lot of opiate use disorder people come in here. He's like, what? I said, people that are addicted to opiates. He goes, no way. I said, so I kind of gave him the breakdown. So what happens is it does give a partial hug. And if you go ahead and read online, Dr. Google says if you want to get off of your opiate addiction, to take 5 to 7 boxes a day of this. Now, obviously, to common sense people, 5 to 7 boxes of anything that's over the counter probably isn't good. But in the layperson who just thinks it's over the counter, it's not going to hurt me. Who cares if I take more? More is better. Well, here's what's going to happen if you take more. There's your normal EKG, right? And if you take 5 to 7 boxes a day, this is what can happen. And the internet doesn't tell you this. So I know some of you medics out there are going, oh, torsades. And for you BLS people, you can look at that and it doesn't, you don't have to be a cardiologist to read this and go, yeah, the person's not going to live very long. That's nowhere near normal EKG. This is what can happen. So we're kind of detectives. When we go into a scene or if we go into a car, it's been a motor vehicle crash or somebody slumped over and you see boxes of loperamide, you might want to go ahead and give them some Narcan because they might have respiratory depression or arrest from that, and they might be having getting torsades from this. So that's kind of what we've been seeing around here, and it's been a nationwide trend because Dr. Google says do it, and people trust it because it's over the counter. It can't hurt you. All right, let's talk about some weed. I was shocked to find out in your state, in South Dakota, that anybody at any age can purchase Delta 8. I had to read it twice because I looked right at your state's website as far as whatever the Department of Marijuana is, whatever the equivalent is, and it is not illegal to sell children Delta 8 gummies. I was absolutely flabbergasted. Now, I live in a pretty liberal state, all right? We don't even do that. As a matter of fact, Delta 8 is technically illegal in our state. They're not going to do anything about it. But you guys can do Delta 8, Delta 9, which is regular THC is Delta 9, and Delta 10. And they can sell all these products. Now, it does say in the article that, or actually in that website, the government, the South Dakota government's website, that don't be surprised if they don't sell it to you if you're not of age. But that's an individual decision made by that store. That blows me away. What's interesting is I did this talk just over a week ago when I was in Brookings, well, Elkton, near Brookings, and did that research in preparation for that talk. And since then, I've actually seen an article that South Dakota is rethinking that. Thank God. I thought our state was screwed up when it came to marijuana laws because, yeah. So anyway, you guys have the most, at this point in time, unless they change it, have the most liberal gummy THC on the books anywhere in the United States, which is totally just blows my mind. But anyway, it is what it is. So here's the different forms of THC that are utilized, whether you smoke them, vape them, or put them in edibles. Delta 9 is your regular THC. Now, when I graduated from Osseo Senior High, which is a northwestern suburb of Minneapolis, in 1983, and I wanted to get stoned, I approached the dude on the corner of the campus, gave him a $5 bill, and if he gave me a nickel bag, $5 worth, of weed, and it was the good stuff, it was either Colombian gold or Thai stick. That stuff had between 2.5% to 5% THC content. Now, some of you younger ones out there are snickering. I told that to my youngest son and daughter, and they laughed. They go, "Dad, we wouldn't even use that stuff for free. It's crap weed." It's like, well, it made me laugh at Scooby Doo and made me eat too many Funyuns. Well, we didn't have Funyuns then, but potato chips or burritos or whatever. And we basically sat on the couch and it really didn't do anything. Well, we've reached an age now where you can do dabs or honey oil. That's little tiny dabs of 90% pure THC, and you put them on a hot spike, and it generates smoke, and you quick suck it in with a specialized gas mask that you've modified and get really super stoned instantly. So these are all the different formulations that are out there. And like I said, in your state at this point in time, Delta 8, Delta 9, and Delta 10 are all legal. And the Delta 8 and Delta 10 can be sold to anybody at any age, potentially, if they're willing to sell it to them. I can't believe it. All right. So the good news, when you smoke it, and if you ever know anybody who like to get stoned, they don't like to get paranoid. All right. They get noisy if they take a giant hit of something that's really good. And like, dude, man, the government's coming after you. It's like, dude, put the bong down, have a bag of Funyuns. It's going to be fine. Within a couple of minutes, it dissipates. Because when you smoke it, it crosses your blood-brain barrier pretty quickly and you can titrate your high. Now, here's the problem. When you ingest it in the form of gummies, potato chips, all those products that are out there now in the form of edibles, it changes into 11-hydroxyl THC, which is more psychoactive and much longer acting. Okay? So here's a typical scenario. And a lot of people think since the government, everybody trusts the government, and I'm not a conspiracy theorist or anything. I'm just saying that if the government says it's legal, then they wouldn't put out something that's going to be dangerous in any amount because a lot of people don't have common sense. So they'll go ahead and they'll take maybe a half of a gummy because it says take 1/2 to 1 full gummy, per serving. All right. Well, so you take a half one because you're kind of scared. It's your first time. Well, you wait 15 to 30 minutes and you're like, dude, nothing's happening. So what do? We'll take more. Well, how much more should I take? I don't know, take 3 or 4. More will be better, and they wouldn't sell it if it was dangerous. Well, guess what? When you ingest it, it's got to go through our mouth. It's like taking a Tylenol. I equivalent it to like this. Let's say I've been on the scene of a fire for like 12 hours all night. It's a big fire. I'm getting old. My back hurts. I go home, take a warm bath, and I take 2 Tylenol. I'm not going to get relief from that Tylenol for a while because when I take it by mouth for at least an hour or so, right? Because it's got to go through my mouth, down into my stomach. It's got to dissipate, go through my hepatic portal, through my liver, into my central nervous system, where then it might take away some of the pain in 1,000 milligrams. It's the same thing with edibles. More is not better. And so we're a really super patient society, right? Not. So when you go ahead and you take your half, nothing happens for 30, 40 minutes. You take more and you take way more than you're supposed to, you can't take it back. I guarantee you there's people out there who are listening who have transported people who've gotten agitated, not necessarily violent, but so paranoid they had a feeling of impending doom where they had to go to the hospital and get benzodiazepines. ERs, as we know, are overwhelmed. Hospitals are overwhelmed. We never really fully recovered from COVID. EMS systems are not well equipped now. They're down in personnel and staffing. And so the whole idea behind the poison center is keeping people out of the hospital 92% of the time. And our respective states have saw fit to go ahead and introduce this, which is now causing problems in adults and more so in children. Now, I will say this. As far as any of the Delta 8, 9, or 10s, no matter how many were taken, we have not seen any serious medical issues in adult patients. No seizures, no cardiac problems. They do get high blood pressure and tachycardia because when they get paranoid, that's a fight or flight response and they feel like they're going to die. They're really not. That's just a feeling that they have. If they just suck it up, buttercup, and stay at home, they'd be fine. But Most of them feel terrible and they can't. All right. So now, when we talk about children, it's a totally different deal. We're finding out that children are having respiratory depression or arrest. We had one kid who went 13 hours after ingesting gummies and went asystole with no underlying cardiac problems, no cardiogenic problems, nothing like that. We've had many people describe seizures, legitimate seizures in the healthcare setting and seizure-like activity pre-hospital, and kids that have only taken marijuana. We've actually, and the way we know this that nothing else is in their blood is because we've tested their urine, their blood, and all that's in their system is THC. So kids can have life-threatening effects from eating these gummies, and they look fun, don't they? So these can be very dangerous in children. So if you are responding to a child who's potentially ingested edibles, watch for their respiratory rate, watch for any seizure-like activity, and use benzos-PRN if you're able to do that at that level that you're at. And we can all manage airways and breathing at any level that we're at, but they all need to go to a hospital if they have any symptoms at all. If they're just stumbling around and, oh, maybe we should just give them some Funyuns, it'll be cute. No, it's not cute. They can actually have serious outcomes from regular marijuana in the gummy. So just want to set that record straight. We'll skip that one. Well, guess what? So maybe you got a teenager or a young adult male that lives in your, or female that lives in your house like I do, and maybe they partake in the ganja once in a while. Well, guess what? If they get it from a different dealer, it can be contaminated with fentanyl and they can die of an opiate overdose from smoking weed. We don't see a lot of this, but there have been confirmed reports in the Midwest and all over the United States of people stopping breathing from smoking weed or utilizing marijuana products because they're adulterated with fentanyl. And so I've talked to people and they're like, dude, that's effed up, man. Why would they do that? We just want to get stoned. I don't know why, but that's the fear. Now in Minnesota, we can grow up to 5 plants now legally. So I've encouraged my friends and family who decide that they want to smoke marijuana, which is their legal right now, to go ahead and grow their own plants. That way they know that there's nothing adulterating it. Or I've even told people that have, but that, I've responded to that have had fentanyl contaminated weed that we've had to use Narcan on, to go ahead and ask them, did you buy it from a different dealer? Yeah, how'd you know that, man? Well, because that's probably the reason that it happened. So, and they're like, yeah, our dealer went on vacation. We didn't stock up, so we got it from some other dude. So just smoking weed now can go ahead and end your life. This is the world we live in. So treat the patient, not the poison necessarily. All right, that's it for drugs of abuse. We could go on. I could go on for literally hours about drugs of abuse. Just some more fun things. We do. If you ever heard about licking toads, like on The Simpsons, you don't just lick them. They have to be a certain species, and you got to squeeze their little heads on the side of their heads to get this their venom out of there. Then you put it on a glass, you let it dry, and then you smoke it, and then you see pretty cool stuff. What's interesting about that is the toxin is actually closely related to digoxin. So if some of you know have been around a while, one of the adverse effects of having too much digoxin in your body is you see yellow halos and get visual hallucinations. That's kind of what this is doing. So I'd recommend that you do something else other than smoke toad venom. So the other one is snakes. So there again, this is if anybody is near the reptile gardens and they want to see the Mangshan vipers, that's these two here. And those eggs are now hatched, and some of the babies are at the reptile gardens also. I was directly responsible for getting these beautiful snakes to the reptile gardens, working with Terry over there, and another one of my friends who, mutual friend of ours is Terry, who is my mentor in how to manage snake envenomation. So these are Mangshan vipers. There's less than 500 in the world. They come from one area, a 40 square mile area in the side of a mountain in Mangshan, China. And they're very, very endangered. They'd never previously been hatched in captivity. And the guy that got bit here on his arm, you can see one fang mark on his right forearm. That's where Mama Bear got into him. He said he used to handle the snake all the time. Her, not him. He said the male was kind of a prick and he didn't like handling him because he's a little sketchy. And these are, 5 to 6 foot green snakes. I mean, they're dangerous snakes. But he said the mom, the female, was always nice. But obviously he didn't get the memo about when they got eggs or cubs or whatever that they turn into Mama Bear and she bit him. Well, this is only the second envenomation in recorded medical literature of a Mangsheng viper envenomation. So we were able to get him to the reptile gardens so as conservation. And I know some of you hate snakes, but they actually do perform a good service in the ecosystem. So if you ever get to the reptile gardens, go see the Mangsheng vipers. They're really super cool. More likely, you're going to encounter prairie rattlers in your state if you're in an area that has them. Basically, everywhere west of the Missouri River in South Dakota has prairie rattlers. They are the third, they're not the largest species of rattlesnake in the United States, but they're the third most venomous. I did a retrospective review of 43 envenomations over a 12-year period in South Dakota and a couple of North Dakota. There were no deaths. What we did see, though, is 2 people had to get intubated because they had what we call an anaphylactoid reaction from the venom. And so they got angioedema and their airways started closing up and they had to be intubated and had an advanced airway placed. So one of the things about them with the prairie rattlers in South Dakota is if you ask the question if they've been bitten, ask them if they have tingly lips and if they have a metallic taste in their mouth. Because if they do, that kind of is an indicator they may have had a more serious envenomation. Just get them to any hospital. There's one antidote for all rattlesnakes in the United States, and that's pretty commonly available everywhere in South Dakota. So we can usually save their lives. We jokingly say that if you have a set of car keys and you get bitten by a rattlesnake in the United States, if you can get to a hospital within a couple of hours, you're going to survive. You're not going to die. We do plants and mushrooms. I know mushroom season is coming up for me. I'm very excited. I am a forager. But if you're an amateur forager and don't know what you're doing, there's a saying, don't munch on a hunch. So, or all mushrooms are edible, but sometimes only once. So be careful. So these are the morels, and I know you guys have morels in South Dakota. I go forage for them. The ones on the left are real morels. They're about 50 to 100 bucks a pound. I don't sell them. I eat them because I love them. And the ones on the right are false morels that can cause intractable seizures if you eat them or boil them. Here's a way to tell the difference. This is the easy way. There again, if you don't know what you're doing, you don't pick up a guidebook and do it on your own. Find out somebody knows what they're doing. The regular morels will be hollow inside, maybe a couple of bugs here and there. The false morel will have fibrous material inside if you cut them top to bottom. The one on the right was actually a death in 2022. We had a death from a mushroom. This is an Amanita bisporingera. This does grow in the Midwest. The one on the left here is a Chlorophyllum molybdites. If you cook it, it's edible. The one on the right, if you take one bite out of there, which is all that was eaten, you can die from this, and it causes liver failure. You need to call the poison center if anybody has eaten a mushroom that's potentially poisonous. That one can kill you. So, in closing here, just want to remind you guys, get accurate sample histories. Now you have matters histories if you want to use that. Get good at doing the ABCs. And I'll say this, doing good ABCs, even at a BLS level, saves more people than all my fancy antidotes. Obviously, there's exceptions to that. But by and large, just doing good EMS ABCs is going to save a lot of people's lives. But don't forget to call us because we can take a lot of the fear out of this. You can give me a list of 15 medications if somebody's overdosed on or a kid got into it and go, no, they might pee more, they might be more drowsy, or ooh. If you hear the ooh, my sphincter just tightened and that might be a bad day for you. But we know what's going to cause a problem as quickly as you can tell us. Don't forget to use your South Dakota Emergency Medical Services for Children. I know Corolla and Jamie in the office there. They do a great job. They have lots of resources for you, like car seats and Carter kits for the autistic children. Really, really great resource. If you've never utilized them, go to their website. So the 3 takeaways I have, call 800-222-1222. That's the universal number to the Poison Center. If you get any of your 1s or 2s off, you'll get a porn line. We've tried all the iterations of it. They don't speak too dirty to you until you give them a credit card. So nothing too R-rated or X-rated there. Treat the patient, not the poison. We've harped on this. And nothing is what it seems. If you remember those things, you'll be gold. Just remember these guys. Keep yourself safe. I knew Adam. I didn't know Adam super well. I trained with him a couple of times. But his partner, I know very well. He's a young kid that I got into the fire service. But you know what? Anything can happen any day, despite as safe as we want to keep ourselves. So thank you for what you guys do and keep yourselves as safe as possible. So with that, if you want 2 more nationally accredited EMT ICCR hours, you can go to our website at training.mnpoison.org. You can go ahead and take it's supposed to be 2 hours. It takes about 45 minutes. And then you can go ahead and get 2 more credits free of charge. We are working on a module for marijuana, so keep an eye out for that and some other modules to expand upon that. If you have other questions, you can email me. There's my email there. And once again, thanks for what you guys do. I hope you guys have long, wonderful careers. And that's really all I have for you. So I'd be happy to take any questions if there are any.
It looks like there was a couple of questions in the chat. One of them was asking, where can you buy the CO detectors?
Um, I just Googled mine, and you can get them from like Granger. You can get them from any EMS or the bigger, I would say, like EMS supplies places, that kind of thing. So just Google it, and you should be able to find something in there. There are a lot of them under $200, and they're good for 1 to 2 years. And I would recommend getting the kind that actually clamp onto your bag with that like clip on that you have to cut off with a wire cutter, because as we all know, even though people shouldn't be taking things, unless they're locked on there, they're going to disappear eventually. So, good question. Are there any other ones? I didn't open the chat here. Let me. I see somebody says we have them in our jump bags. What are some other? Oh, that's too big. So complete the survey. Thank you. Did you see any other questions?
Nope, I think that was the only one. Right.
Perfect. If anybody has any other last second ones, just punch them in quick. Otherwise, you can always call the Poison Center. Ask for me. Hopefully this was useful for you. Please call the Poison Center. As you found out, we do a lot more than just overdoses all the time. We're there for you in EMS. Please call us.
Awesome. Well, with no more questions, thank you so much, Kirk. We appreciate it so much.
Thank you. Have a wonderful evening.
Bye, everyone.
Bye now.